and Mass General Hospital. Today our presenter is Dr. Dilruba Yasmin, and the topics of discussion of today's the tumor board is carcinoma cervix. The tumor board discussion is usually start with the MGH in every survey. And today our topics is carcinoma cervix, and the presenter is Dr. Dilruba Yasmin. She is a gynae-oncologist from National Institute of Cancer Research and Hospital. So I think at first probably Professor A.M. Hai sir, the president of the oncology club, he has not yet joined. So I request Dr. Kamaluddin Bhai to start the session. Please, Kamal Bhai. Kamal Bhai, please.
Maybe he can't hear us.
He can hear us. Yeah. So I think that I am in the airport. There is some network problem here. So today this whole session it will be conducted by Dr. Rifa Tara, is Assistant Professor, National Institute of Cancer Research and Hospital. So I request the Dr. Rifa Tara to introduce the presenter and all the faculties. Dr. Rifa Tara, please. Rifat.
Yes. Thank you, Professor Shahana Parvin, Madam. Today our presenter is Dr. Dilruba Yasmin. She is gynecologic oncologist at National Institute of Cancer Research and Hospital. I am requesting Dr. Dilruba Yasmin to start the presentation. Dr. Dilruba Yasmin, please. Dr. Dilruba?
Yes, I am sharing.
Okay.
Thank you, Dr. Rifa Tara. Assalamu alaikum and good evening. Mrs. X, 40 years, para 2, living 2, normotensive, non-diabetic lady, presented on January 2022 with the complaints of lower abdominal mass and excessive pervaginal discharge for last 1 year. Her menarche was at 12 years of age and she used oral contraceptive pill for 10 years. She had no personal or family history of ovarian, endometrial or colon cancer. On examination, there was a 12 into 10 centimeter abdominal mass which was firm in consistency and in the right lower abdomen. Pelvic examination reveals an endophytic growth present in the cervix. The pelvic mass corresponds with the continuous with the uterus. The right parameter is involved, left parameter is free. CT scan of whole abdomen was done in 14 January 2022, and it reveals a right-sided loculated complex mass adherent with the right admixture about 6.7 into 7 into 9 centimeter, with right-sided hydronephrosis and hydroureter due to involvement of the middle one-third of the right ureter within the mass and right lower lobe pulmonary consolidation. This is the gross right-sided hydronephrosis, and this is the complex mass in the right admixture, and this is the right admixture mass with and the cervix also broad, and there is a growth in the cervix. As CT scan of the whole abdomen reveals right lower lobe consolidation, we do CT chest, we do extra chest, which also reveal right-sided consolidation in the lower zone. So CT chest done on 21st January, and it also reveals the same findings, right-sided lobar consolidation. and CT-guided FNAC also done, but which reveals inflammatory lesion. Her tumor markers C125 is 223 unit per ml, and other tumor markers reveals normal. So core biopsy from the right ovarian tumor was done, and it reveals serous cyst adenocarcinoma, and cervical biopsy reveals squamous cell carcinoma grade 2. So our diagnosis is carcinoma cervix 2B with malignant ovarian tumor. And this patient was discussed in the tumor board, and tumor board decision was chemotherapy followed by evaluation for surgery for ovarian cancer, or if surgery is not possible, then CCRT plus ICRT. Accordingly, she received 6-cycle chemotherapy with paclitaxel and carboplatin up to 11th June 2022. After completion of 6-cycle chemotherapy on 21st June, the patient presented to the outpatient department of our institute, and we found a abdominally the mass was increased in size, that is 15 into 10 centimeter, firm in consistency, and occupying hypogastric right lumbar region with restricted mobility. Pelvic examination reveals cervix is broad, barrel shape, no visible growth. The mass continues with the uterus and with restricted mobility. Both parametrum is free. Before NSCT, the right parametrum was involved. After chemotherapy, parametrum is free, and her post NSCT C125 level is 36 unit per ml. This is her post NSCT chest X-ray, which revealed no consolidation. And this is the post NSCT CT scan of whole abdomen on 21st July 2022. This picture shows the mass is increased in size and adherent with the abdominal wall, and there is right hydroureter and hydronephrosis with inhomogeneous cervix. This is the right-sided gross hydronephrosis and hydroureter. This is the cervix. So the decision for surgery was taken, and she underwent laparotomy on 29th August 2022. Operative findings was the firm mass fixed with and adherent with the rectus sheet of the abdominal wall. The appendix was embedded within the mass, and the mass encasing the ureters and internal iliac artery, and there was an enlarged right iliac lymph node. The mass was adherent with the anterior abdominal wall and rectus sheet, and this is the right-sided hydroureter, which was encasing with the mass. And modified radical hysterectomy with debulking surgery was done. Appendicectomy, omentectomy, and pelvic lymphadenectomy. This is the omentum. This is the right adnexal mass, uterus, cervix, and this is the enlarged right iliac lymph node. This is the gross section of cervix, which reveals grossly there is the growth, and microscopic feature of the ovary. This is the HPR of ovary. HPR histopathological report of the ovary shows squamous metaplasia, and this is the HPR of cervix. So histopathology report reveals papillary serous cyst adenocarcinoma high grade in the right ovary, omentum free of tumor, left ovarian fallopian tube free of tumor, cervix invasive squamous cell carcinoma grade 2, stromal invasion present, LVSI present, but lymph node show reactive change. Thank you.
Thank you, Dr. Dilruba Yasmin, for presentation of a rare and interesting case. We have 10 panel of experts today from Harvard Medical School and Massachusetts General Hospital. May I request Professor A.K. Goodman to conduct the panel discussion session?
Dr. Yasmin, that was a beautifully presented case. Thank you so much. And that was most interesting. I would like to hear from my colleagues, Dr. Castro and Dr. Melamed and Dr. Gockley, about their thoughts about this case. maybe start with Dr. Castro. What are your thoughts or questions from hearing this?
Yeah, I apologize. I think I may have missed some critical component. This patient was previously treated, and then this was occurrence here.
Yeah, so Dr. Yasmin, she presented with what you thought was an advanced cervical cancer, and you treated her with neoadjuvant chemotherapy with carboplatin and Taxol. Is that correct?
Yes,
Yeah, and she received how many cycles of chemotherapy? Was it 6 or 3?
before surgery, she received 6-cycle chemotherapy with paclitaxel and carboplatin.
Right.
6 cycles. Wow.
Yeah, so Dr. Castro, she had a biopsy showing squamous cell, and she was treated with the idea that this was all a cervical cancer, with the idea to try to shrink it for surgery, which is a very common strategy in Bangladesh, because unfortunately, the majority of women that they see there with cervical cancer present with advanced stage inoperable cancer, and they push to try to shrink it to get them to operability. It's a very common strategy in Bangladesh.
But what I find concerning is that, with carboplatin paclitaxel certainly should have addressed the ovarian cancer, and then to have persistence there will make us it's concerning for either platinum refractory or at best a resistant.
Could we look at the pathology, please, for the high grade for the serous ovarian cancer? Because one thing I was thinking is along the same lines as Dr. Castro. High grade serous ovarian cancers in 60, 70, 80% of cases will respond to primary platinum-based chemotherapy. But low grade serous cancers have a much lower response rate. Other types of epithelial ovarian have a low response rate. So one thing I would love to get, if this was my patient here in Massachusetts, I would definitely have the pathologists look at it again to help guide, what the final pathologic diagnosis is on that serous cancer, just to make sure we are dealing with a high-grade serous cancer. If it's a high-grade serous cancer, I tend to agree with Dr. Castro. You're in a really tough situation because it's a platinum refractory high-grade serous ovarian cancer, and there are not a lot of great moves in that situation. But if it's, for example, a low grade, then actually you have quite they're good options, or at least there are options to think about where to go from here. So could we look at the microscopic imaging of the tumor?
Dr. Yasmin, can you move your slides to show us the pathology slide? Unfortunately, our pathologists are all at the IGCS meeting, and I'm not on this call.
Cervical pathology before chemotherapy.
And then could we see the final ovarian
When the
pathology?
patient first came to us, we take cervical biopsy, and this reveals squamous cell carcinoma grade 2. And this is core biopsy from right ovarian tumor.
That does look rather high, doesn't it? So I'm not, again, I'm not a pathologist, but it does. So, and do we have the final pathology from the ovary? I think we saw that also, right, from the resection.
This is the
Yeah.
final histopathology of ovary.
It's very high grade looking.
So some things that I've seen folks do here when we have serous ovarian cancer or epithelial ovarian cancer that doesn't respond to upfront carboplatin paclitaxel. One thing we do here, which I'm not sure is available, unfortunately, in Bangladesh, is sometimes we send these tumors for genetic testing to identify mutations that might be targetable, usually because we're looking for a clinical trial that we could put a patient like this on, because again, there aren't a lot of great standard of care options. I've also seen some medical oncologists, and I'd love to know what you think, Dr. Castro, switch from carboplatin paclitaxel to cisplatin gemcitabine. I don't know that there's a huge amount of evidence to support that, but I've seen that as a next line for folks who don't respond to carbotax.
Yeah, I mean, it's all predicated on how the patient is, performance status, or how she tolerated the 6 cycles and surgery, and then the timing to that. Otherwise, since she just recently completed Taxol, we think about platinum-resistant strategies, and so our go-to are usually weekly Taxol plus an anti-angiogenic such as bevacizumab. And if that's not available, weekly Taxol as well. But since she's already received it, another second agent that we use is liposomal doxorubicin. That's available there as well, and that's given monthly. But the scenario is certainly worrisome. And if there's any opportunity to look, as Dr. Melamed had mentioned, the genetics. It could be important in that respect. The role of immunotherapy in this scenario is pretty much very limited.
Kamal sir, can you speak to the availability of chemotherapy in Bangladesh?
Yeah, thank you, Ike. We are having this liposomal doxorubicin and also the bevacizumab. Immunotherapy is not readily available, but we can manage, but the cost is quite high. But my question here is what Alex was telling, or Castro is telling. So once we gave 3 cycles, for example, in ovary, forget about the cervix, we said there was no response, we could switch to other protocol and see the response. Now, once the surgery is done, is there any way to understand, say we give whatever the protocol, liposomal or GEM or whatever it is there any way to understand that it is working? Because we will assume that maybe it will work unless there is a recurrence, because we have removed the mass. I mean, unfortunately, probably we don't have any way to assess the response. Any comment on that?
Fair. I think, short of just checking CA-125, values every month or so. I would agree.
Yeah.
Go on, sorry.
No. I completely agree. I think it's challenging, as you said, in general for ovarian cancer, we usually do 3 cycles, right? Operate and then 3 more cycles. So once you've given 6 and then had a complete resection, it's challenging to know what to do. I think usually, particularly because this looks like an aggressive cancer that didn't respond very well to the initial chemotherapy, I still favor giving some adjuvant treatment after the surgery, but I think it's hard to know exactly how much, and what it should be. But I think it's it feels bad, for lack of a better explanation, to just see this and not to give some additional treatment for the ovarian.
Quick question. I thought that her chest x-ray showed a nodule. Is that something that could be followed? So that'd be my one question. And my other question to Dr. Yasmin and the team in Bangladesh is, what is the role for placing ureteral stents? That was quite a dilated ureter. Was her renal function compromised? Could that play a role in the ability for her to... Please.
Please. This is the right-sided hydroureter, which the mass was increasing the ureter, but her serum creatinine level was normal. Maybe the hydroureter, maybe the cause of the hydroureter, maybe compression of the mass.
I also want to just congratulate you and point out to everyone what amazing surgeons are present at NICRH. Just the kind of surgery that you all do is very radical, very excellent surgery. And this is an example of that. So I just want to congratulate you on that. But back to the point about the lung, is that thought to be related to her cancer? Can that be followed?
I think X-ray is not a fair thing for this type of situation. At least a CT scan must be done if we are assuming there is something. And then if we are convinced, say if of FNAC or something, we are convinced adequately, definitely that can be also a surrogate of follow-up after giving some adjuvant. I have a quick question to MGH group. So if this is a scenario, a patient came to you in the clinic, confirmed diagnosis of both the pathology, what would be your way of addressing it? I mean, both the cervical cancer and ovary is confirmed. I mean, how would you have approached? Just. Okay, you need to unmute.
Yes, thank you. Actually, I'd like to ask Dr. Mazina, who's on the call, what her recommendations would be.
Good morning. Sorry for the delay. I think that proceeding with the neoadjuvant chemotherapy makes a lot of sense. I think just like Dr. Mallard was saying, if there's an opportunity to assess for interval response after 3 cycles, that could be helpful. But I feel like proceeding with the neoadjuvant chemotherapy, particularly with someone with that volume of disease, I think is exactly what I would probably do as well. And I'm also just really amazed by the size of that ureter. It's really mind-boggling.
I'm curious, would anyone in the group consider radiation as part of a neoadjuvant or neo approach, preoperative approach, given that she had a cervical cancer, or would you go straight chemo here?
Well, can someone remind me what approximately was the size of the initial cervical lesion? I think that helps me figure out how to think about it. So I guess it doesn't exactly matter, but I guess I would say, if she was if the cancer was potentially curable surgically, the cervical cancer was, right, then I think an approach might, and you knew that the mass was ovarian, I think one approach might be upfront surgery. Sounds like there was a barrel cervix from my recollection of the presentation, so it doesn't sound like an upfront radical hysterectomy was a real option. And I think in this situation, I really think that even though we don't do a lot of neoadjuvant chemotherapy in the United States, I think it does make a lot of sense, because I think it would be hard to give both neoadjuvant carbotaxol and to do concurrent radiation, and it would make me very nervous to not treat the ovarian cancer while we were treating the cervical cancer. So I think the approach really makes sense. While we know, or while there are some trials that suggested that neoadjuvant chemotherapy followed by radical surgery is a little bit worse than definitive chemoradiation for locally advanced cervical cancer, in this situation, you might just have to swallow that slight disadvantage, to be able to treat both cancers concurrently. I think the overall approach is right. I think, the one place where, as Dr. Mazina said, I think we would have rescanned at 3 cycles and sort of reassessed what was going on in terms of potentially switching the chemotherapy, or operating at that time. But I'm not sure it would have made a big clinical difference for this patient. It seems like she just has something that's very genetically, nasty growing from her.
Dr. Gockley, first of all, I'd like to, send a shout out to you. We're very excited to have you on staff at Mass General. Other thoughts about this case?
Yeah, I mean, I echo what everyone has said in the fact that this is a very complex presentation. And I think, my thought when we were going through this was just sort of, what is bothering the patient the most? When you're faced with these really interesting therapeutic dilemmas, I think I'd be very curious about, did she have certain symptoms that were the most bothersome to her? And I might incorporate that into my decision-making in terms of how to decide what to do first. I agree with Dr. Malamed. I think that it would make me really uncomfortable to do primary radiation, knowing that the ovarian cancer is sitting there and knowing that that often grows faster than the cervical cancer. But if a lot of her symptoms were based on the pelvic burden of disease from the cervix cancer, I think your hand may be somewhat forced in that case to prioritize the cervix cancer.
Thank you. Thank you. I wanted to maybe go back to Dr. Castro. You had mentioned that immunotherapy was not something you would consider here. Can you teach us a little bit more about?
No, absolutely. Thank you. So for ovarian cancer, we certainly explored the use of single agent immunotherapy, given the momentum that it had in lung cancer and melanoma, and we haven't seen any movement. Early clinical trials have combined immunotherapy, specifically nivolumab, with bevacizumab, and we are seeing some response there in platinum-sensitive ovarian cancers, and less so in resistant. And so we currently have a trial of that same backbone, nivolumab plus bevacizumab, and adding a PARP inhibitor, rucaparib, and not so much for the original intention of PARP inhibitors, for example, from a DNA repair issue, but just more to help the nivolumab potentially. That being said, these are only under trial, and so nothing yet from an FDA approved or standard of care scenario. So unlike endometrial and cervical cancer, where immunotherapy is going to be an important, or is already an important component of the therapeutics, we're not yet seeing that in ovarian cancer. And I guess it speaks to the heterogeneity, of the ovarian cancers. And so, and to close the loop on this patient, if indeed we get a chest CT and we see that there's some disease that could be tracked, I would proceed. And thank you for kind of enlightening me about the use of doxil and bevacizumab being as a potential therapeutic. I would start with that. And if we see that the chest mass decreases, then we're making some progress there, and then checking another CT scan in maybe 2 or 3 months after that. And if we see a plateau, so no more further shrinkage, that's as good as it gets. I would recommend stopping the doxil and then continuing on bev as a maintenance, because again, this is already very, very clinically concerning.
It's very interesting. In Bangladesh, there's a lot of industry, and one of their industries is the pharmaceutical companies, and they do make their own chemotherapy in Bangladesh. Isn't that right, Kamal?
Yeah, you are correct. We are having the advantage of low income countries, so we can make many generics. So that is a very good news. But the worry news is that we don't have any data on these molecules. So not even the phase 4 trial like data of outcome. So sometimes we are not very much confident, but we use it because the price is much cheaper than the originator. So this is a good news, but also a worrisome news. In oncology, if we are not really using the molecule, we are missing the opportunities. Like PARP, we are getting very cheap. We are getting most of the drug generic, but unfortunately, we don't have any organized data, outcome data. I wish we had that. then I mean, it would be great to have, I mean, the unbelievable cost per P available. I mean, example I'm telling, almost all drugs they're making generics now. That's a great news, no doubt about it.
Yeah, so Kamal, what you're bringing up is another question which we don't really think about in the United States, which is which particular chemotherapy source did the patient receive? And is it possible when you don't see an effect, are you truly getting effective drug, or are you getting a lookalike that's maybe not really a good chemo drug? So is that person really truly chemo resistant, or is it just that they received cheap chemotherapy that might not be actually the chemotherapy that we think about? Isn't that right, Kamal?
Yeah, I mean, I will not say like that. I will say that, they have the chemotherapy, but their main concern is the toxicity. Castro can say better, but sometimes, I mean, if we are not very sure about it, we don't know. As you said, we cannot really make a comment about non-responder. We cannot make a comment about the side effect. And what I'm scared about, say, we have the history of handling drug-resistant tuberculosis. I don't know, I mean, whether we are unknowingly creating drug-resistant clones by using this type of molecule. I'm not against this thing, but I wish we had more robust data on this easily available. When it's biosimilar, when you are in USA, you are using biosimilar. You don't need to worry about it. But these are generics. There is no such comparison, not even single arm data. So that is a question mark always we carry, but considering the cheap availability, we use it. But as you mentioned, if there is a good result, we are happy. If not the result, we back of our mind, it comes, maybe, it could be, we don't know.
It's a fascinating additional issue that I don't think we think about at all in the United States. So I just want to point that out to
Thank you for bringing that up. Yeah, that right now that it's not something we certainly do not appreciate. So that's for me, it is very.
Another thing is, Castro, that here our companies are not making it. Say X company is manufacturing one molecule. Today they are bringing it from Y country. Tomorrow they may import from another source, because this is not a fixed source. So once we are happy with one, for any reason they change their source, we will not know, because on the face we know one company. So, but the generic originator, they have their fixed source. They cannot change their source. So for the generic, the biggest challenge is nobody is making it their own. They are either bringing on China or some European countries. We don't know. So what is their source? They are not always, we cannot go deep into it. So these are the challenges that we are facing. What AK brings it up, that sometimes it is good to have cheap drug, but sometimes we need to think about that whether it is really cheap or not.
So it's so interesting. I'm noticing the time, and I want to be sure that Dr. Melamed has an opportunity to teach us in our remaining 15 minutes or so. And then if we do have some time, to open that up to our colleagues in Bangladesh for any other questions. So maybe Dr. Melamed, if I could ask you to take over.
Professor Goodman, we have another
Sure.
case.
Thanks so much.
I know, but we have to, unfortunately, have to leave for our surgery in 20 minutes. Yeah, so I think probably we should.
If time after her lecture, then we can discuss it in short. Okay.
Yeah, let's do the lecture, and if we have time, we'll see. Okay. Yeah.
Okay,
Yes.
I'll be quick to leave room for the.
Share. Let Alex share the screen.
Yeah, if someone could. Oh, here I have it. Thank you. You've let me share. I appreciate that very much. Okay. Excuse me. Okay. Okay. Can you guys see my slides?
Yes, we can.
So I hope this is interesting to you. I know that the tools for minimally invasive surgery are still emerging in Bangladesh. But this is an interesting story that played out over the last few years that I think many of you probably are familiar with, about minimally invasive surgery for early stage cervical cancer. And I just wanted to go over kind of the recent debates to convince you to be on my side of the data. So, my only disclosure is my mother actually works for Intuitive Surgery, which is the company that makes a surgical robot that often people use in the United States to do minimally invasive surgery for cervical cancer. But as you'll see, I do not favor its use. So I wanted to just review the history of minimally invasive radical hysterectomy for cervical cancer, present the data, and then just convince you that open radical hysterectomy must be considered the standard of care, and that minimally invasive radical hysterectomy should only be performed in patients enrolled in clinical trials or in unusual circumstances. So I think we all know, the radical abdominal hysterectomy is an old operation, first performed in 1895 in the United States, and then further developed by surgical giants in Austria, Japan, and the United States to the procedure that we inherited. And this procedure, remained largely unchanged until 1992, when the first minimally invasive radical hysterectomies were performed. And in the United States, this procedure was really taken up after the Intuitive Surgical Company got approval for the surgical robot, which is a really neat toy for doing laparoscopic surgery, which a lot of folks think makes it easier. And you can see from 2006, when this robot was approved, to 2014, more than half of radical hysterectomies in the United States became minimally invasive. And in fact, this procedure was so well received and so frequent that many guideline writing organizations like the NCCN and the European organizations considered minimally invasive radical hysterectomy the standard of care by 2015. And in fact, the European guidelines recommended it over open surgery. Now, I think a thing to point out is that we made a mistake that is commonly made in medicine when this happened, and that is that we were basing our recommendations on very flimsy evidence. We didn't have any randomized trials comparing minimally invasive and open radical hysterectomy, and we had observational studies which had many problems. They were small, they did not control for important differences between patients who got open and radical hysterectomy, and often they compared results current surgical care with very old surgical care, which obviously is not always valid. So we did an assessment of these old studies at some point, and we really found that many of them were just too small to precisely measure. Almost all of them were too small to precisely measure the true effect of minimally invasive radical hysterectomy. And I think we all, or many of us, heard that in 2018, a randomized trial, which had been initiated, many years before, was finally published, which randomized patients to open versus minimally invasive surgery. And this study did find that patients who had open surgery did tremendously better than patients who had minimally invasive surgery. I'm going to skip this slide, but this trial, the LAC trial, was a randomized open label non-inferiority trial. It randomized patients one-to-one to either abdominal, laparoscopic, or robotic radical hysterectomy, patients who had at least FIGO stage 1A1 with lymphovascular invasion through stage 1B1, the old 1B1 were included. And this trial was actually stopped early because they noted too many deaths in a minimally invasive group at their safety monitoring meeting. And so to go through the most recent data from this trial, it was presented at this year's annual Society of Gynecologic Oncology meeting by Dr. Pedro Ramirez. You can see that there are almost four times more occurrences in the minimally invasive group as there were in the open group. in that the disease-specific survival was significantly worse for patients who had minimally invasive surgery, and the overall survival was also worse. So really concerning findings. We did an observational study actually around the same time that we published, and we found that the observational data really supported this randomized trial data. So we found that if you look at patients in the unit that had robotic minimally invasive radical hysterectomy, those patients also did worse. And also we found that following the rapid adoption of minimally invasive radical hysterectomy starting in 2006, while survival amongst early stage cervical cancer patients who were surgically treated actually started to decline. So the trend that was preceding changes started to decline. And so after these two papers came out, there were a lot of other papers that started to look back at the results. And it turned out that there were a lot of cases where we were seeing worse survival. We summarized some of those, some of the better papers, the ones that really tried to do a good job to control for confounders and have appropriate controls and so on. And we did find when you sort of pool all the observational data, and the observational data really does line up with the randomized trial data. And the one other sort of strange wrinkle in the story is, the whole reason for doing minimally invasive surgery is we expect patients to do better from a quality of life point of view, to heal faster, to have fewer infections. And the quality of life data from this trial, actually from the LANCE trial, was really surprising because it didn't really show that minimally invasive surgical patients did particularly better than the open surgery patients on any of these quality of life surveys that we usually use. And so I think very surprising for those of us who do a lot of minimally invasive surgery, because in general, we do think that the patients recover a little bit better. So I think the take home from this, what my argument is that today, the preponderance of evidence really does suggest that minimally invasive hysterectomies performed robotically or otherwise have harmed patients. We don't really know why, okay? There's a lot of theorizing. People argue that it's the technique, the manipulator, that there's things that you could potentially do to mitigate this risk. But the truth is there's uncertainty. And until we prove that there is a safe way to do a minimally invasive radical hysterectomy, and the only way to prove it is with a large randomized trial, we should consider the open procedure the standard of care. And there are randomized trials that are ongoing. There's several. There's one in the United States. There's one in, I think, Sweden. There's one in China that are trying to figure out, I think, whether there is a safe manner to do this procedure. But I think until those trials are published years from now, the open technique is the standard of care. And I really appreciate your attention, and I'd be happy if anyone has any comments or questions, but I know there's another case you guys want to squeeze in the next 10 minutes. I want to let you guys try and do that.
Thank you very much, Dr. Alex Mil-Ahmed, for your very rich and informative presentation on radical hysterectomy. Particularly, these data are very important for us because we are a low resource country and we have limited facilities for minimally invasive surgeries.
So you guys have been doing it right the whole time.
Yes.
So no hard feeling. No hard feeling for not doing minimally invasive.
Professor A.K. Goodman.
So that's something good. That's something good for us. Alhamdulillah.
Yeah. Hi there. I'm actually curious, and again, I'm sorry, I don't think we're going to get to the other case, but I'm curious if to hear from our colleagues in Bangladesh. Number one, how much minimally invasive surgery are you doing now in the setting of cancer? And then also, do you have any other questions about the first case or thinking in generally before we say goodbye?
So AK, is there any thought on the case of giving adjuvant radiation from your radiation colleagues? I want to hear about that. At this stage, surgery is done, 6 chemo is given. Now we know the histopathology. We justified it. We did a good job. Thinking of some more adjuvant chemo. What about, because we know cervix, it was surgery. Will there be any role I would love to listen from your radiation oncology colleague.
Yes, it's an interesting question. I think before answering it, I want to get that chest CT scan and see what's going on in the lungs. But even without much going on in the lungs, I wonder if you might want to just save that radiation for later, because she has this complex double primary that's going on. And you did a very nice surgery for her, and you wonder what exactly is her risk factors. You worry it's more the ovary than the cervix at this point. I'm curious what other people think about that.
So some surgeon colleagues may respond to a case question about the minimum invasive surgery from Bangladesh. Shahana is there. So as you know, there is no robot in our country. The practice is laparoscopic. I'm not very aware of doing laparoscopic for cervical. Some practice of ovary is there, but not very common. But our experience of laparoscopic surgery is not great, because unfortunately in ovary, we don't see a very good clearance through laparoscopy. So we try to convince our colleagues not to go for MIS in either ovary or cervix. I mean, we try to convince, but well, it happens. Sometimes, you know, it was misunderstood, not being thought it is a benign case. They take out the ovaries and they do, and then finally it came out malignant. It happens. And sometimes then they go for completion. I think from a non-surgeon's end, this much I can tell from Bangladesh. The surgeons are keeping silent.
Actually, in Bangladesh, we have queue in surgery, as minimally invasive surgery require more time. So we don't prefer usually in hospital to do minimally invasive surgery, even in selected cases. We prefer to do open surgery. And particularly in cervical cancer, we always do open surgery in Bangladesh.
I see that Dr. Shanor Islam has raised her hand. Doctor, please talk to us.
Good evening. Actually, we do not do minimal invasive surgery in case of ovarian malignancy or cervical malignancy. We always prefer open.
In the United States, our most common indication for minimally invasive gynecologic oncology surgery is endometrial cancer, which I know is not very common in Bangladesh.
Yeah, Alex, it is not that common, but I want to bring a caution here that I remember once Tom was telling that doing MIS, even by laparoscopy, needs a great skill. Otherwise, it is not a very comfortable thing. So in our country, total practice of MIS is not very common. I mean, a selective group do great job, but unfortunately, they are not always oriented about the oncology. So the mix of laparoscopy and oncology is very much required. So till now, we are trying to campaign in our country that probably it is better to avoid MIS in GYN malignancy in our setup yet. That is what is going on. And we are happy that majority of the colleagues are not doing it, except some few exceptions where our experience is not great after the surgery, what we see. Because patients are not happy to go for completion surgery. You know, once one surgery is done, it is very challenging to convince them to, hey, you know, we didn't knew it was malignancy, we need to do the completion. It is sometimes challenging, cost involvement, and also morbid.
Well, I wanted to thank everybody. It's incredibly moving to me to connect around the world, to think about the friendship and the ability to connect and ask each other questions. It's a true blessing. And just wonderful. I think for us in Boston, we were very, very excited and privileged to have the connection with you all. So we're very excited. For those of you traveling to New York, please safe travels. And we look forward to the next meeting, maybe sometime in December, I think, because in November, there's the Oncology Club meeting in person in Bangladesh. So that's pretty exciting coming up. But anyway, maybe any other thoughts or comments from the Boston crowd? Okay, well then we'll just say goodbye for now and see you soon.
Thank you, AK.
Thank
Bye,
you so
everyone.
much for having us.
It's a great opportunity for us. And now we are knowing each other, and credit goes to you connecting each other. So now friends in Boston now becoming a common face. And we are so happy to share our experiences, and we hope to carry it forward. And thanks to all the colleagues in Boston from oncology attending. And believe me, this is a feather in our cap. Working together, discussing with the MGS friends, it's a feather in our cap, and we take it as a prestige. And I was in a meeting in Mongolia. I told to my colleague, hey, I have a meeting with MGH group, so I need to go. So it was, it was a prestigious thing for us. Thanks for giving us the great opportunity, and we are really learning and sharing our experience. And I'm so happy to see our junior colleagues are coming up, courageous enough to present case in front of great physicians like you, sharing their thoughts, challenging you, putting you in trouble. I really enjoy. I mean, we are really enjoying it. So see you soon, virtually, and why not also physically. Thank you. Thank you very much.
Okay, take care.
Well, thanks from myself
Bye.
also. Thank you all very much. Really, I enjoyed the discussion this evening. Yeah, every morning it was a nice session. Thank you all the friends from MGH, particularly Catherine. She is with us for a pretty long time, helping us in many ways. Today we can see lots of friends. And my friend, thanks to Dr. Dilruba Yasmin for presenting the nice paper today and discussion of this. Without it, really, I want to get farewell from you. Goodbye, everybody. See you soon. Bye. Bye. Bye.
Bye.
Salam, sir.
Bye.
Walaikum salam.
Salam. Assalamu alaikum.